Hello, my name's Dr. James Gill, and this is our 60k Q&A. I'll be honest, I'm astonished. I never even thought that just trying to help out students doing demonstrations of the medical videos that we've done and subsequently explaining would result in, this little channel that we've got, but it's here, and well, thank you all for that. And I suppose this is just a little bit of a way of me saying, let's have a look behind the curtain and see what's going on. You guys have clearly been brimming to ask some questions. On the post that we put up on the comments, we've had over 70 responses. So I can't guarantee we're going to go through every one of the questions, but we're certainly going to try for the majority. And perhaps to make sure that this is as honest as I can be, I haven't actually paid any attention nor looked at the questions beforehand. So I'll be honest, there is probably going to be the few that I will skip, but for the vast majority, you're going to see the answer as I come up with them here and now. If so far you've enjoyed watching these videos but haven't, I'd be really grateful if you could subscribe to the channel. The more subscribers we get, the more engagement with yourselves we can generate through the community posts and things like that, and hopefully help you guys with whatever examinations, whatever medical stresses it is you've got. And perhaps that's something that will be worthwhile touching on in the future. Perhaps some video on the stresses of medical students and of doctors at the moment, particularly in this current COVID era. With regard to COVID, I must confess my stress levels are on the way down at the moment because I've been very lucky that I've had my second Pfizer jab. I'm waiting to find out what superpowers I get as a result, but perhaps more importantly, my overall worry about getting COVID when I go to work will be reduced. But perhaps even more importantly, means the probability of me getting a haircut has increased significantly. Yes, I'm not a fan of the current mop, but still. One of the things that might be worthwhile mentioning, as I say, COVID jabs, I have had a few patients that have tested positive for COVID after having had the various vaccines. However, both of those patients, one didn't actually know they had COVID and it came up on a swab, and the other thought that they had a mild cold. So on that side of things, we know that the headlines that the vaccines reduce severity and reduce hospitalisations have been effective so far. I think personally one of the reasons I've been so terrified about COVID is the long-term tiredness as much as anything. I can't stand to be tired. I much prefer, when it comes to medical things, to almost be in pain than that. Tiredness, it's so all-encompassing, which is one of the reasons I have such sympathy for, but frustration that we're unable to significantly help patients that have fibromyalgia and chronic fatigue syndrome and things like that. So the fact that COVID is likely to result in more of those has been a personal worry of mine, and I think that we're going to be dealing with the aftermath of this pandemic long after the infections have dropped off. So, with that as an intro, let's grab the iPad and see what we've got. So, Leah Baker has asked, what are your thoughts on physician associates? Well, physician associates are a relatively new concept, certainly in the UK. I'm aware that America's had them for a while. And broadly, I think that they're an excellent idea. The main problem that we have with healthcare is service provision. Now, what do I mean by that? I mean literally the putting in cannulas, drug chart, reviewing patients and seeing how things are ticking along. It's what an awful lot of time we spend doing as junior doctors. And as doctors progress through their their foundation years into specialist training and then registrar level and consultanthood, they stop doing that coalface work because they have been skilled and they have been trained and they have developed further expertise. That means it isn't the best use of their time. They're much more effective, for example, in theatre or in the front line of the A&E department, managing things there, or perhaps in clinic, trying to assist and assess patients with very complex diagnoses. Now, that's not to say that physician's assistants can't also help out with those tasks, and I know some very, very impressive orthopaedic physician's assistants who work in clinic and assess patients as well, because they've got that specialised knowledge. But broadly, I'm very pro the whole idea of physician's assistants in order to help fill the short gap that we have at the moment when it comes to coalface ward work. And I hope that as and when those things change, the physician's assistant's role is allowed to evolve further. But we'll have to see where things head with that and how that will come about. Okay. I have 7 cats. Says, what sandwich combinations do you feel gives the most apparent sandwich breath? Thank you, Dr. Gill. Fine, I'll play it. I am aware from discussions with yourselves in the comments about, I think sandwich breath is a meme, or is a hark back to another clinical examination video performed by another consultant. So I can see where that comes from. But let's answer it straight off with a typical medical approach. So if we're going to be looking about sandwich breath, we want to be thinking about stimulation of cranial nerve 1, the olfactory nerve. So we want to think about what's going to have, the strongest volatile compounds. So that's going to be something that could be, transmitted through the air potentially. And interesting enough, actually, that makes me think. I did some research when I was at working at UCW, developing an electronic nose. Yes, I kid you not. This nose was designed to sniff out particular cancers in patients' urine samples, and it's proven to be quite effective. But for one particular, unfortunately rare form of cancer, interesting enough, the neuroendocrine tumour. Now, happening in the tech world, there's a few of you who may sort of have an itch in the back of your head and think, where do I know the phrase a neuroendocrine tumour from? Well, that was what actually Steve Jobs suffered and unfortunately died from. So we do have technology to detect that much earlier now, and that electronic nose was part of it. So to answer the question, what's going to have the most volatile organic compounds? Probably something with garlic in it, an awful lot of garlic, perhaps something with fish, maybe mackerel. Not quite sure I'd want a mackerel sandwich, but something like that I'm sure would be particularly pungent. Mind you, I suppose if we're talking about sandwiches, I personally can't stand Marmite, so that would put me off, certainly. Okay, moving on. Tony Mowbray. One of my friends is from Melton Mowbray. Absolutely excellent pork pies over there. When COVID is over, if you live in the UK, if you want a day trip and something to do, there's a place, Brockleby's I think it is, in Melton Mowbray, where you can actually go to their factory and make your own Melton Mowbray pork pies. And they have a vast range of different pork pies. I must confess, so my first degree was at Nottingham University, specifically Sutton Bonington, a farming campus. And I was particularly disappointed to find out that the Brockleby's pie, beaver pie, didn't contain any beavers. I was quite disappointed there. And also their penguin pie also didn't contain penguin. I'm not sure what a penguin pie would taste like, but I'm assuming it would be rather gamey. Sorry, we digress. So, what are your hobbies/interests outside of medical practice? Do you like sports? And if so, do you have a favourite sports team? Well, I don't consider myself to be particularly sporty. The vast majority of my friends would probably disagree, but I prefer to consider myself to be quite active. I like running. I'm trying to get my 5k time under 19 minutes 30. I quite like cycling, and one of my colleagues, Ralph Mitchell, he's a GP in the area who I was at medical school with. He and I have gone up Alpe d'Huez in France, and later on this year, well, with COVID not allowing us to travel significantly, we're going to do the Wiggle Dragon Ride in Wales. 200 kilometres and I think 1,000 metres of vertical climbing. I've not gone that far yet, and I'm not looking forward to it. So yes, they're the things I do outdoors and indoors. I quite like reading. People know that I have a soft spot for Arthur Conan Doyle, but as well as that, from a very geeky side of things, I occasionally do Warhammer painting, because I find that's a little bit like swimming. It's sufficiently engaging that I have to concentrate on it, but at the same time it's not a challenge for me, it's not a chore, should I say, but it's also sufficiently engaging that I can't think about other things. So it's quite grounding in many ways, when there's all stuff from work churning away in your head. Okay. Can you do informative shorts on various topics of non-typical but often enough seen disorders and diseases that provide facts and dispel myths, like HIV, palsy and autoimmune disorders? A lot of these things people have heard about but don't really understand, and the lack of info hurts people who have them and prevents those who might from getting properly diagnosed. That's from Earl Grey all day, I'm not necessarily sure if we could start doing a short series, but I like the whole idea of dispelling myths is something that we can incorporate into the A to Z of NHS topics that we do. And again, this is a really good way of us developing the format. So if there's things that you guys want to suggest, please shout out and we can look at developing that side of things, because it's there. That A to Z of the NHS, we're hoping that is more, a person who's interested in medicine rather than medical student level information. Okay, you seem to be really good at putting patients at ease. What are the secrets to your ways? From Kayla Coate. I'll be perfectly honest, I'm not sure that I am good at putting patients at their ease. Certainly some of my patients may disagree with that. If I'm good at putting patients at ease, I would say it's because I am honest with my patients, and perhaps, in my opinion, a lot of anxiety comes from the unknown or not understanding. And one of the things that I've found with the medical school is that I have an ability to explain things to people. I'm not good at maths, is a good example. I really had to bleed to pass A-level physics. I couldn't do the formula part of it, but I could do all of the stories. And I think that's perhaps why I'm good at explaining concepts, because rather than a Homo sapien, an intelligent chimp, I consider myself to be a storytelling ape. I'm very good at telling stories and visualising them, and maybe that's helpful to the patients, that they know exactly where they stand with me. So Jason Parson asked, why is the male pelvic floor overlooked so often? It's not so much that it's overlooked, it's that it is a less common area of issue. And this is the big problem with medicine. Common things are common. To deal with a urinary tract infection, a patient is going to come in and they're going to say, it hurts when I pass urine, I'm passing urine more frequently, I don't feel well, I may have a temperature, and I've probably got tummy pain. That makes an awful lot of sense for a diagnosis, and we'll do the requisite workup for that. A chap that's having problems passing urine, or maybe not, we're going to be thinking down urinary tract infections or other types of infections in that area. But it's only when all the common things that make sense, that have been tested for, trialed, treated for, and the issue hasn't resolved, that we then have to look at the unusual. And I think perhaps the best way of looking at that is an idiom that we use at medical school. If you hear hooves, think horses, not zebras. Certainly in the UK, a horse is more common than a zebra around here. But the point is, common things are common. And unfortunately, that does mean that some things don't get the attention that people suffering from them would like. But then that's about keeping knowledge in your head. And this is one of the things being a general practitioner. I know a little bit about an awful lot of things. But for something like, male pelvic floor dysfunction, my little bit of knowledge is not really going to touch on that. So I'd need to send him up to a specialist to get the advanced care that would need. Okay, Gracie Forster. I'm starting a nursing degree in September. Any tips? Yes, be prepared for being more tired than you'd expect. You're going to have to take a huge amount of information and store it in your head, and that's going to be difficult. So things that I would recommend: making sure you've got snacks with you all the while, making sure you've got at least a week, and that sounds a lot, but at least a week's worth of food ready, prepared and frozen in your freezer, so that when you've had one of those days and your brain just can't take it, you can come in and not have to worry and just put something in from the freezer. And with that, you're going to stress, you're going to do so much work. And one of the ways that you will try and do it is you will try and cut down your sleep. You'll do all-nighters or long sessions. The problem is that is counterproductive to your learning. Because if you reduce your sleep, let's say for the sake of argument that you get 7.5, you get the minimum that's considered good, and you reduce that down to 5 because of extra study, you're going to be losing the additional sleep cycles that tend to build more frequently as you sleep for longer. So for example, you'll get like an hour, 45 minutes, half an hour, 20 minutes. That's not the actual timings, but my point is that they come more frequently the longer you sleep. If you reduce your hours of sleep, you're going to get less sleep cycles and less consolidation, less free learning of that knowledge that you've spent trying to cram in. So that's probably going to go for medicine and a lot of other subjects as well. Champion and value your sleep if you're trying to learn. Okay, to Jada Gulvers, I hope I've not completely savaged your name there. Is it true that the emergency services have a locker with special objects removed from people? I believe that's going to be a no, because a lot of those things are going to likely be disposed of, because they've been removed from people, so we'd probably put that down as clinical waste. I feel that that's an urban myth. Let's put it like this: would you really want to have a box with things that had, for want of a better phrase, human tissue or fluid on it? So for one, well, let's put it another way. Would you want to have a box in your office with things that have been removed from orifices? I think, whilst it sounds entertaining, it would actually probably be rapidly unhygienic. So no, I think that's an urban myth there. Question 2. Why are there so many doctors who don't listen at all to what the patient says? That's a very difficult question, because I'm sure that the vast majority of doctors could have that levelled at them at one time or another. And there's going to be multiple reasons behind it. How stressed the doctor is. These are not necessarily reasonable things. These are things that I'm suggesting in that. What's just happened to that doctor? You don't know what their last consultation was. And again, it's not right, and you need to be able to transition between patients, because it's it's important that each person is treated as an individual. But if you've just overrun and you've just spent the last 20 minutes explaining to parents that their 12-year-old child is dying, and then your next patient comes in with something that you're perceiving as trivial, it may be difficult for you as a doctor to change gear in order to give that patient the right level of care and attention. Again, it's not right. I'm merely answering some potential issues why that could be. Sometimes it may feel that somebody is not being listened to because actually the points that are being raised are being dismissed. More likely though, when someone feels that they're not being listened to, often what can be going on is that they're not getting their expectations met. So it may be that the doctor has completely listened to what the patient has said, but has perhaps missed what the patient was hoping to occur as an outcome. So let's say, as a simple example, you've gone in with an ear infection, and the doctor has done an assessment and feels that everything here is viral, and thus says that antibiotics here aren't appropriate. That patient might feel that they've not been listened to if they feel that their concern, their worry, their possible desire for antibiotics hasn't been addressed properly. So there can be a myriad reasons why consultations may fall down in that regard. Okay, I'll be perfectly honest, I ummed and ahed about this. Question 3. Can a man's willy really break and therefore stay crooked? I saw it on the news. It was quite a weird explanation. Okay, let's talk about penises. The penis is actually an amazing bit of engineering. So it becomes erect because of blood supply going in, because of vessel dilation, and at the same time restriction to blood flow coming out. Okay, makes sense. What can happen though is it's possible that one of these vessels can become damaged, and thus you don't get the straightforward normal erection. Now that can often be due to scar tissue, and there are conditions called Peyronie's syndrome where scar tissue will occur on one side of the penis and result in an erection having a bend or a kink to it. Now there is a classic example of people ending up with damage to the penis was actually cowboys. And you see them sort of jump off something on a film and land on their horse and then ride off. Well, actually, that severe damage and trauma to the perineum could injure those blood vessels and could potentially break a willy in that sense. Didn't expect to be talking about that on this one. Okay, right. I'm going to leave that one there because I think that we've got a few questions there. So Margaret Curry, sorry, one more question. What's a good experience you've had, funny, satisfying, emotional, etc., that will always stick in your head when you look back on your career? I'm going to say bizarre, and I'm going to have to go back to the island for this. One of the girls down the beach had collapsed, a combination of exhaustion and lack of fluid. And I went to do a house visit, and it was just very strange. Wearing a dirty jacket, which is actually still in there, a dirty jacket with my stethoscope round my neck, soaked army boots, walking along a beachfront to go and do a home visit in essentially a mud hut lean-to that we'd thrown up. So that's probably one of them, the oddest ones. Yeah, I think I'll stay with that for the moment. Okay, so Shinky Winky asks, what's your favourite subject to teach at medical school? Well, obviously clinical skills is obviously my field, but I think my favourite part of that is the abdominal examination, because what with my sister having Crohn's, inflammatory bowel disease, I have a lot of interest in abdominal issues, and particularly the diet side of things. So that's probably why I quite like that, and I can probably often expand upon the questions that are asked me more easily there than I can, for example, on psychiatry, when we teach the mental state examination. Answer Pectoralis, advice for American and medical and pre-medical students. I'm not sure why that would be any different than any other medical students, but generally sleep more, find somebody who will work with you and at your level. I was very lucky that my clinical partner and myself could push each other quite often. You don't, in my opinion, you don't want someone who's going to help you or facilitate you to coast. You want someone who's going to challenge you in a good way, to make you work harder, to make you, compete, but in a positive environment. That sounds a strange one, but it's, you know, he and I would take histories from each other, and we'd always try and make the history more difficult in order to both aid the teaching of each other, but also to make us think harder about what we were asking patients for. And perhaps with that, be careful whose advice you buy into. We're all different. I'm kind of a night owl. And if someone tried to give me advice on how to work as a morning person, how to get up and go for a run and everything like that, it just would not work for me. So if you try and fit yourself into someone else's revision schedule or someone else's map for the perfect doctor, that's not going to work for you. And maybe this is as much of a life tip as it is for medical studenthood. Find out who you are and what it is that you need to do in terms to maximise your learning. And that can take time. I think it was the second year of medical school before I properly found my groove, because the work level at medical school is so much higher than it is with a regular degree. Alexis Groner, do you watch ASMR? I'll be honest, I don't. It's quite as simple as that. I know that lots of my friends, which is how they told me about the comments on the videos in the first place, do, but not for myself particularly. Aaron Stewart, as a psychiatric nurse specialising in crisis mental health, I was wondering if you have any psychiatric experience during your medical training, and if so, how did you find it? I was placed at one of the psychiatric hospitals here in Coventry, and I think the training that you get depends on as much about your lecturers and the consultants and the experiences you have there. We were certainly given good teaching with regard to how to do the psychiatric assessments and the mental state exams, but I definitely think that it's something is viewed as quite a niche specialty to develop your interest in after medical school, unfortunately. Daniel Lee, please tell us about that digital stethoscope you use. How come you use that instead of a standard stethoscope with a bell and diaphragm? Okay, well, I actually had a standard stethoscope. Bought it when I went to medical school on eBay, because a stethoscope really is not a complex bit of kit. It's a tube with a bit of metal cupped on the end. The initial purpose of which was so that doctors didn't have to put their ears on patients' chests. I didn't have my name on my stethoscope because it was second-hand, and it's normally a free service provided by stethoscope manufacturers. And my stethoscope disappeared when I was working in ITU. I have no idea where it went to, never got returned anyway. And my grandparents, who raised me, they offered to buy me a replacement stethoscope. And knowing that these things, are medically speaking lifetime things, they said which is the best one you can get, and we looked at this electronic Littmann stethoscope, and they very kindly bought that and had that engraved. Unfortunately, my granddad has passed away, and thus that stethoscope that I have absolutely means the world to me. It's with me every single day at work, and it's just having that small aspect of him with me still today. And like the classic concept of replacing the broom handle and the brushes and then the actual screws and things, when do you have a new broom? The stethoscope has had all parts apart from the exterior metal case replaced, but it's still that same stethoscope as far as I'm concerned, and it's still got the original engraving, Dr. James Gill, that they had put on it when they gave it me. In terms of is it any better, I would argue not for general medicine. However, you can increase the volume on it with the electronics, and that can be particularly useful for quiet murmurs. But not only that, there's a filter built into it which is tremendous for paediatrics. So I will do a first pass over a child's chest through their clothes before getting them to undress and then having another listen. Because once a child starts crying, it's very difficult to get them to stop and get an adequate assessment of them. And they're more likely to start when you get them undressed because they were quite happy and warm. Okay. Max R, would you ever go full-time as a YouTuber if the channel got big enough? More than anything, I would miss the students that I interact with. And yeah. There's something magical about lecturing when you've got a room of students and broadly they don't understand the concept and you know they don't and they're struggling with it, and you change tack and nothing works, and you change tack and they're still not getting it, and then you go completely off-piste and throw a weird way that my brains work to understand the concept, and then you see the light bulbs going on. That's one of the best feelings there is. And I'm grateful that certainly with some of the deep dive videos, I know that I've helped people on here, but it's quite different when you're doing it with the students there, I think. Sarah Armand, did you always know you wanted to go into medicine? And if not, what other career paths did you consider? Well, I'm told at home I always wanted to be a doctor. I don't honestly remember that. I know I tried to get to medical school the first time around and fortunately didn't, so I'm a graduate entry medic. And I think if I had another opportunity to go round, I'd probably try engineering because I like the idea of making something, having a tangible effect and say, yeah, I did that. It's probably one of the reasons why I'm really enjoying doing these YouTube videos, because I'm creating something. And that creation is hopefully giving people some benefit. Cucumber Sniff, it's an interesting name. Favourite biscuit? A triple chocolate shortbread biscuit, which is just on the right side of it undercooked. So when you squeeze it, it gives ever so slightly. So you've got that slight, almost gluten-esque bend to it, as opposed to a straightforward Walker's biscuit where you pick it up and it snaps with quite a brittle sound. But then I suppose it's the same thing. My favourite cookies are ones that have that, again, that slight gooness to them. When we have baking here at the house, I'm always inclined to take the cookies out of the oven just fractionally before they're done. And if you pick them up with a spatula and you put them on the cooling rack and they just seep ever so slightly into the cooling rack. It's like, that's right. I don't like a biscuit, that cracks. I much prefer a cookie that you can bend. No idea why, but that's just the preference there. Adam He, hey Doc, how are you holding up with COVID still disrupting life anywhere? What tips on maintaining a healthy mentality in this trying time? I'll be honest, it's been difficult at times, and I have had a few grumpy days. Find someone to talk to, and maybe that means professionally. I know that the NHS is offering counselling sessions for doctors at the moment, and I have availed myself of some of that. I'm also doing a lot of running. I'm trying to get out. I'm trying to get sun on my face. And, even just running through the fields here, trying to get that exposure to nature. And there's lots of studies saying that actually perhaps rather than doing 10,000 steps a day, we should be aiming for 2 hours of exposure to green spaces in a week. I think it's in a week. But that's one of the things that I'm trying to do. The other thing, and I think that you guys have seen it here with the ebb and flow of the frequency of the videos, is some days not a good day, and I'm accepting that, and I'm not pushing myself on those days. And if that means that I can't edit, and if that means that I can't film, I'm not beating myself up about that, because there's sufficient things going on at the moment. And perhaps this is where it all boils down to. It's about trying to find things that you have what's called an internal locus of control for versus an external locus of control. So an external locus of control are things that are external to you and that you cannot control. So the COVID pandemic is a really good example of that. And then we need to balance that with the internal locuses of control. Now that doesn't mean that these are all going to be good things, and similarly the external locuses of control are not necessarily all bad things. But I have control of those which are internal. And if I'm having a bad day, I will say, right, I am going to deal with this by leaning into it. Conversely, I may have, know that I'm actually having a really bad day because of things going on outside. So I'll lean into my internal locus of control, and perhaps I will go and do some painting because I know that that will remove some of the thoughts going around in my head. And it's playing with that balance, but the internal locus of control is going to be crucial to maintaining that positive, not mental state, but finding positive things to improve your mental state, because it's where you have control. And a lot of issues at the minute are because people don't have control. Cornelius II asked, do you use a certain type of paper for the thyroid PutABitofPaper test? No. I said I could have so much fun with this. Yes, absolutely. It has to be premium grade, 100 gram, unbleached paper from the finest paper mills. No, just straightforward paper grabbed from the printer tray as a rule of thumb. Okay. What was your driving purpose or reason to get into medicine? Okay, I consider myself a scientist that happened to go to medical school. I do medicine because I don't like bench science. What I mean by that is, it was a little, I imagine, again, my inference here, I imagine it's a little bit like a chef, making great food and doing this, and always sending it out and never getting to experience it. With the bench work, I was doing, and I was researching, and I was finding, and I was in the lab one day when somebody found a new apolipoprotein. There was a brief cheer. Everyone, clapped a little bit, and then we went back to work again. And it was so strange, and I kind of felt that I wasn't... It wasn't fulfilling, is the point. So now I have a more fulfilling role in that I take the knowledge that I have and I help the end person with it. And I think that was what I lacked. I was doing medical research, but I didn't have an end... I didn't see the impact, or I didn't see the effect of the work that I did. So it was slightly unfulfilling to me. But that's my issue. And different people get fulfillment from lots of different things. And if you can find fulfillment in something, then that needs to be where you put your energy. And I'll be honest, given that the positive feedback I've had from here, I do find doing the little YouTube channel now quite fulfilling. What are your plans on future medical examination videos? Basically, we're following down everything that we teach at the medical school. So I know that we need to do a formal assessment of the eyes. I want to do ears. We filmed the GAL screen, gait, arms, legs and spine last week, so that's still to come, hopefully in the next 7 to 10 days. I need to try and do something with dermatology, but that's going to be a challenge. We'll see what we can find. But there's still other things to come. And I think once we've perhaps dealt with all of the clinical examinations, which is not going to be for a while, we may look at trying to focus on medical techniques and things, procedures. Alan O'Regan asks about hypochondria. Any general advice for people who suffer health anxiety? Yes, go and talk to your doctor. And that's not flippantly. A big part of health anxiety is the worries. And because of the nature of the worry about health, which is largely something we don't have a lot of control over for big things that we're worrying about, I go back to that internal and external locus of control, speak to your doctor. And perhaps that's going to be getting explanations about what you're struggling with. Maybe it's going to be getting treatment. Maybe it'll be trying medication. Maybe it's refer for counselling. But that's something that you definitely need to speak to your doctor about, and we will definitely be able to help with that. I see lots of patients with health anxieties, particularly at the moment, and each patient has to be viewed on their own as an individual. So I can't give you one tip other than talk to your doctor and let us help. Susanna Roble says, have you had students who've chosen to study at Warwick after seeing your videos? I doubt that. I haven't, and I doubt that would be a thing. However, I have had 2 students commented that subsequently they'd seen the videos before they came to Warwick, but I would imagine that those were just part of researching the nature of the courses that they were doing. Mackie Med, hi, I love your videos. Any advice on bettering one's social skills, in particular when taking a history? Introverted medical student here. If you're an introverted medical student and you're struggling to take a history, I personally find the baptism of fire to be particularly helpful. And that's involved in terms of building confidence in asking people personal questions. So go and ask, can you sit in the gum clinic, the genitourinary urinary medicine clinic? The questions there are so penetratingly personal. Once you can master a gum consultation history, you'll be absolutely bomb-proof for asking anybody any other questions. And that's kind of the second bit of advice there. It's about repetition. Medical school is strange. We have boundaries, social boundaries. You don't, say for example, it'd be really frowned upon in the UK to ask about someone's income. And there's lots of things that you don't ask about. And then you go to medical school and you get to ask this host of the most personal questions you could ever imagine. And that's really jarring initially, particularly when you have these thoughts, well, I'm just a medical student, I'm nobody, I can't ask these things. I remember the first time that I was asked to write in a patient's notes, and the consultant laughed at me because I sort of reacted as if I've been asked to write in a holy tome. There are these mental hurdles or barriers that we provide to ourselves that get reduced with exposure and get reduced with, confidence. So in terms of proving the history, get out there and do that. And in terms of improving the history questions, there is a fabulous book, Dale Carnegie's How to Make Friends and Influence People. Read it. It shows you the wonder that is human language, and it'll show you how someone will respond differently depending on how you phrase the same question. And it's a fabulous book for understanding the interaction with people. And that's what a big part of medicine is. It's a human skill job with a bit of science tacked on. Amanda Almeida asks, when do you suppose we can return to our normal lives, as in pre-COVID? I don't know. I'm hoping that, let me rephrase that. I'm working on the hope that it'll be September. Now, the reason why I say that is we need to have goals. There was a really interesting study that the benefit of a holiday is not actually the holiday itself, but it's the work-up, the lead-up to the holiday, that goal of a break. And that's how I'm viewing this with COVID. So I'm viewing that September 2021, in the UK at least, there'll be a lot more return to normal. That may not be the case, things may change regrettably, but I'm working toward that. It's far enough away that I think it's likely, but it's close enough and tangible that I've also got that hope to keep me going at the moment. So that's what I'm working with. But I think even if medically things improve, I think society-wise it's going to be quite difficult, for example, for me to go and sit in a cinema for some time, I think. We'll have to wait and see. Sarah QZ, be honest, how do you feel about the PutABitofPaper comments? You seem to have fun with it. I'll be perfectly honest. I've been entertained, and I really don't mind. A lot of my view on this sort of things is if it's bringing people entertainment or fun or positivity, all power to you. If something's not hurting somebody else and you're getting engaged in entertainment by it, that's tremendous. At the moment we've got so many things that are negative in the world. anything that can be turned into a positive, tremendous. I mean, I personally really dislike my voice. It never sounded like anybody I was growing up with, and when I hear it recorded, it still makes me cringe. But some people have found that it resonates with them, and all power to you. I don't think that it's likely to be something that's harming anybody, which is one of the reasons why, you know, I've engaged, and I'm also so very grateful that you guys have engaged with the concept of the work we're doing here and helped this channel become what it is. Emma Jeannie Beanie's asked another question, but I kind of like it here. Do you have any advice for younger people trying to figure out what they want to be? You seem very happy in your field, and I just wondered if there was any guidance on how you knew or what you did to discover what was right for you in the world. I'll be honest, I think I've been very lucky. I've sort of bumbled and fallen into things. I tend to fall upwards with some of the mistakes that I've made. A good example was the videos that we did. They initially started off as a result of a disagreement about some other work, and I ended up doing those, and things have come very nicely from it. Medically speaking, one of the best bits of advice I was given was don't do what... Now, a lot of people will disagree with this, but for people who don't, I think it's good. Don't do what you enjoy, do what you find easy. That sounds really weird, but the second part of it is because what you find easy, you can make enjoyable. But that which you find enjoyable, you may never be able to make easy. And that was a big thing for me. I really enjoyed A&E. Oh, the cut, the thrust, the adrenaline, brilliant. Cutting edge medicine, or coalface medicine directly, anyway. And you got to really have a tangible benefit on helping people, stitching them up and setting legs and all the rest of it. Great fun. But with a timetable that's not designed for human beings. General practice I found easy, but much less enjoyable. However, it's meant that I can do lots of other things with that knowledge, such as going on the island and teaching at the medical school and things like that. So I would advise you to first off look at that, and then whatever you think that you might want to do, have a look at, you know, someone who's doing it. Look at your boss. In medicine we say look at your boss and would you like to be them? If the answer is no, you maybe need to look at a different specialty, because the crucial bit is not the training or the work that you do to get to the goal. The question is, do you like the goal? And training is very hard, it's very difficult in anything you do, medicine, science, engineering, music. But you have to want the end point. And that can be from media as much as things. You know, watch TV, you see a character and say, actually, I really like the way that they've portrayed that character. It may be false. You know, go ask to do some work experience. You'd be surprised the number of people who will actually say yes if you say, you know, I'm interested in your job, your role. Is there any way I could come and sit in for a day or two? You may be surprised at that. So Mark Curry asks, even in the preliminary stages of my own work with patients, I already know that working in the medical profession can be emotionally taxing. It's very difficult to watch someone in pain or suffering, especially if there's not much you can do to help. When faced with difficult situations, how do you strike an appropriate balance, remaining empathetic and caring towards your patients, whilst looking after your own emotional health? That is very difficult, and everyone will have their own ways of getting around this. I'll be honest, sometimes, and I think all doctors will agree with this, sometimes they forget about the person and focus on the medicine, and that's often where people can feel unfulfilled in the patient role. And I think that one way of trying to help and also look after yourself is asking yourself, what is the patient wanting from me, and how will they feel when I give that? So problem that you get with medicine is that you feel like you're giving a little bit of yourself with every patient, and then at the end of the day you feel empty because you haven't completed that circle. And sometimes you have to acknowledge that for my mental health I'm going to have to be late today because I'm going to give a little bit, but I'm also going to receive that same bit back from myself. So working out what the patient wants and needs, and then making sure that I'm or perceiving or empathizing with how that patient is likely to be receiving what it is that they've hoped to get out of that consultation. And I hoped there is a strong word. When we're teaching how to take histories, we ask students to ice the patient at the end, make sure that they've confirmed their ideas, their concerns and their expectations. Personally, I don't like the word expectations because I think it can set up unrealistic expectations. You know, if I'm expecting to have a Ferrari for my birthday, I'm probably going to be disappointed and have a soured birthday. I'm not expecting a Ferrari, it's a Lamborghini. But I argue that we should change that word from expecting to hope, because hope allows things to be changed much more easily. So I always make sure I'm asking and also hope that I can convey with the patient, what was it that you thought was going on today? What was it that worried you? And what were you hoping to get out of today? And then I'm working that backwards. Okay, so I have managed to meet their hopes, I've addressed their worries, and I've managed to sort out what initially they thought was going on. So I'm trying to reinforce and improve my emotional resilience by getting the same benefit as the patient there, if that makes sense. I was just thinking, gosh, it's getting very dark in here. Yes, because the battery was running out in the light. I can now see again. Okay. Hannah Sloan has asked, how long have I been a doctor? So I graduated in 2010, so I've now been doing this for 11 years. And I consider I have two specialties. First being medical education, where I've got, I'm actually qualified in that. I've got the Fellowship of the Higher Education, which I did through Warwick Medical School. And my day-to-day work is that of a general practice doctor. So I'm seeing all patients, which is as challenging as it is rewarding. Matthew MacDonald said, recently posted about the terminology of neurology being its own distinct language. Would you mind explaining a little bit more here? Yes, neurology is completely separate from every other medical specialty in my opinion. Murmurs, blood pressure, abdominal exams, respiratory exams, cardiovascular exams, they all fit very similarly, and you can use very similar vocabulary, or that vocabulary is close, because if you understand the heart, you also need to understand the lungs, and if you understand the lungs, you need to understand the heart. The liver will affect the heart, and the liver's GI system, so they're very, very intertwined. By comparison, neurology very much stands on its own. Yeah, there's a bit of cardiology to it and there's a bit of respiratory, but they are much less. These other words, the arthrotoid movements and the dyskineses and the akathesias, and the Parkinsonian movements and the extrapyramidal symptoms, they're so very isolated from the rest of medicine, very much like psychiatry is. And if you're not using those routinely, when you do come across them, they are so alien to you. Whereas I would have assumed that because the baseline of medicine is respiratory, cardiac and abdominal, the neurologists are going to be much more fluid in the general terms than most generalists are in those specialist neurological terms. Maybe it's just a way of saying it was never my best specialty. I don't know. Okay. Ask AP. Fallon, it's a very succinct question. Fallon, Kimmel, Corden, Colbert, Myers or O'Brien? Colbert, generally. Myers, for a closer look. For those that know, they know, and those that don't know. I think that's the big late night hosts in America. I do like Stephen Colbert. Anybody who can just quote Lord of the Rings, the drop of a hat like that. I mean, his intellect is astounding. I have a huge amount of time for intelligent people, and I enjoy watching intelligent people be intelligent. Now, there's a big difference, in my opinion, between being knowledgeable and intelligent. Technically, the dictionary is knowledgeable, but that wouldn't make the dictionary a very good dinner companion. Having the intelligence is about being able to utilise that knowledge. So yeah, absolutely love Colbert. And Seth Meyers, I like his closer look things. I like the detail with it. I suppose on those, John Oliver as well, his Last Week Tonight, very good normally. I mean, to be honest, of all of them, Jon Stewart was the best, and I'm waiting for him to come to Apple TV, because I've heard he's got a series coming there. But yeah, that'll be good, I think. He's got a sort of a righteous anger that I find particularly refreshing. Almost a little bit Dr. Cox-esque in that regard. Okay, we'll take one more and then we'll wrap up this, because we've probably only got about 3 people still watching at this point. Jacqueline, Rachel, what kind of music do you listen to? I'm pretty much anything really. I have a soft spot for Walk the Moon, Meatloaf, Bare Naked Ladies in all contexts. They've got some, actually, to be fair, they've got some great songs, they really have. If anything, I tend to acquire a lot of movie soundtracks because they tend to choose, good music for that. If I'm revising, though, it has to be classical music, or sorry, music at least, not that doesn't have words. So, for example, I'll have the Lord of the Rings soundtrack and then Jurassic Park soundtrack, and those will go round and round, and that I can concentrate with that. But music, I listen to the words otherwise with songs. Also, would you consider doing more examination videos where the patient presents with more problems or abnormalities? Not just a smooth run-of-the-mill examination, maybe some variations including common problems that can come up during the exam. I think broadly not at the moment. Certainly I'm not going to have patients. We may look at doing some detailed histories where we've got scripts and things and the patient has conditions, and we may use that as a springboard where we then do an examination where we could say what they've found. But obviously sometimes it's difficult to mimic clinical signs in a well person. But we will not have patients, but we'll certainly try to do something on the abnormal side as well. I think that there is utility there for the students, but I can't get patients because of issues with confidentiality and things. Okay, I will give you this and then I will definitely wrap up. Internet dude, do you work out, or have you ever considered to have a muscular body? No. Look at me. I think one of my closest cousins is a stick insect. No. I do subscribe to the whole idea of the endomorph, the ectomorph and the mesomorph body type, and I am aware of my body type, and I have a lot of slow twitch muscle. I'm a good long distance runner up to a point. I'm a cyclist. I've got endurance. No, I am not particularly ever going to consider having a muscular body, because I appreciate that science has its limitations. And on that note, I think we'll leave it there. Thank you very much for joining us so far. I'm enjoying the channel, and I'm really enjoying the engagement with yourselves out there in the community. Please keep dropping the comments in the videos, and please consider subscribing, and if you would be so kind, sharing some of the videos that you've found a benefit, and hopefully we can bring more people in. We've got the 60,000 views now, so it will be, and I can't believe I'm even saying this, it will be tremendous if we could get to 100,000 maybe, next year maybe. And I can't even believe that I'm saying that. So yes, thank you for joining us on this journey and making it what it has been. Literally, if it wasn't for yourselves watching and yourselves getting the benefit and yourselves giving the comments, we wouldn't be here. So thank you very much. Take care, have a good day, and look after yourselves. Cheerio.